In this video, Bakri balloon placement will be demonstrated. Every year, 140,000 women worldwide die of postpartum hemorrhage. In addition to death, serious sequelae such as coagulopathy, adult respiratory distress syndrome, and shock can occur. An estimated blood loss in excess of 500 milliliters following a vaginal birth or in excess of 1,000 milliliters following cesarean birth often has been used for the diagnosis of postpartum hemorrhage. Uterine atony accounts for 80% of cases of hemorrhage occurring within the first 24 hours after delivery. Given that atony is the most common cause of postpartum hemorrhage, it is critical that initial steps consist of emptying the bladder and performing bimanual uterine massage. However, if bleeding persists, the following must be considered: coagulopathy, retained placenta, uterine inversion. Initial management of ongoing blood loss in the setting of uterine atony requires the administration of additional uterotonics such as methergin, carbaprost, oxytocin, dinoprostone, and misoprostol. However, when uterotonics fail to provide satisfactory control of hemorrhage after delivery, tamponade of the uterus can be effective in decreasing hemorrhage. The following are tamponade techniques: packing with 4-inch gauze soaked with thrombin and saline, Foley catheter placement, Sangsten Blakemore tube placement, and Bakri balloon placement. Contraindications to intrauterine tamponade include arterial bleeding requiring surgical exploration, cases indicating hysterectomy, cervical cancer, purulent infections in the vagina, cervix, or uterus, untreated uterine anomaly, disseminated intravascular coagulation, and a surgical site that would prohibit the device from effectively controlling bleeding. Transvaginal Bakri balloon placement will now be demonstrated. The Bakri balloon consists of two ports, one through which a sterile solution, such as sterile saline, sterile water, or lactate ringers, is used to inflate the balloon, and another that is connected to a fluid collection bag in order to monitor for hemostasis. First, the uterine cavity's volume should be assessed by direct or sonographic guidance, and the predetermined volume of sterile solution should be set aside for purposes of insulation. For this demonstration, we have placed approximately 300 milliliters of sterile saline in this kidney basin. The maximum balloon volume is 500 milliliters. In this presentation, the uterus is represented by a transparent water bottle that accommodates a volume of 1 liter, and the cervix is represented by the part of the bottle where the stopper is placed. This area is being delineated will represent the cervical canal, and what is being pointed to will represent the internal cervical os in this video. This bottle costs approximately $7. If the Bakri balloon is to be placed transvaginally, insert the balloon portion of the catheter past the cervical canal and internal cervical os. A ring forceps may be used to initially grasp the bottom portion of the balloon for purposes of guiding the balloon prior to inflation. If the balloon is displaced, deflate the balloon entirely and replace. Now we are demonstrating the inflation of the Bakri balloon with 300 milliliters of saline. A 60 cc syringe containing sterile saline is attached to the inflation port, and serial inflations are performed until the desired volume is obtained. In order to instill the fluid, after attaching the syringe, the stopcock is turned in a counterclockwise fashion, and after each installation, the stopcock is turned in a clockwise fashion in order to prevent egress of fluid. And we have now attained our desired balloon volume. In order to prevent displacement after correct placement, pack the vagina with iodine or antibiotic-soaked gauze. Then perform an ultrasound to assess for proper placement of the balloon once the balloon is inflated to the predetermined volume. A Foley catheter should be placed in order to collect urine and monitor urine output. After the balloon is placed, flush the balloon drainage port and tubing with sterile isotonic saline to clear clots. Then, connect this drainage port to a fluid collection bag. Traction may be applied to the balloon shaft to ensure proper contact between the balloon and the tissue surface by securing the balloon shaft to the patient's leg or attaching it to a weight. Maximum indwelling time is 24 hours. When removing the balloon, first release the tension on the shaft, if any, and remove any vaginal packing. Then attach the syringe to the inflation port. Turn the stopcock counterclockwise and then aspirate the balloon contents until the balloon is completely empty. Gently retract the balloon and discard it. And do not monitor the patient for any signs of bleeding. Now, transabdominal Bakri balloon placement will be demonstrated. If placing the balloon transabdominally, pass the uninflated balloon inflation port first, through the incision in the uterus, and pass it down through the cervix. Then have an assistant pull the balloon shaft through the vaginal canal until the base contacts the internal cervical os. Then close the incision, being careful not to puncture the uninflated balloon with the suture. This slide shows the materials that were used in this video. The references used for this video were the ACOG Practice Bulletin on Postpartum Hemorrhage, which was reaffirmed in 2012, and the Cook Medical Bakri Postpartum Balloon Instructions. Cost of the water bottle was $7. I would like to thank the Department of OBGYN and the Patient Safety Institute at Hofstra University, Northwell Health System, Staten Island University Hospital for their assistance in this video.